I think with the eloquent British accent that Dr. Raj has, I think it's hard to beat him. But beside that, I'm going to convince you that there is a role for intervention in octogenarian patients. So the point of the debate is if you are 80, you should not treat your kidney cancer. Basically, this is how I understood it, and this is not true. We are kind of maybe speaking the same language, but let's start with the basic. What is a small renal mass, SRM? The definition of a small renal mass is an image-detected, contrast-enhancing renal tumor less or equal to 4 centimeters in diameter that are usually consistent with stage T1 renal cell carcinoma. So that's the definition. Of course, we are debating active surveillance versus intervention. And my colleague said that small renal mass needs no treatment. Why? Because 25% are benign, oncocytoma, metanephric adenoma, angiomyolipoma. And even though that it might be cancer, 25% of those cancers are indolent with limited metastatic potential, like if you have a chromophobe tumor or papillary type 1. And so according to him, and according to those who are against intervention, they will say 50% of those are not serious, so no intervention needed. My point is 50% of those are potentially serious and intervention might be needed. So 50% of small renal tumor in general need treatment. This is in a very pessimistic view, but still it's a good number. Now the question is, can the cancer progress in elderly people? The answer, of course, is yes. It can, and it can metastasize, even if it is 4 centimeters. Can the cancer threaten the life? Of course. It can grow if observed. This is one of the drawbacks of active surveillance, and then it can spread and can threaten the life and can, of course, interfere with the quality of life. So I think if you tell the patient, sir, or ma'am, you are 80 years old, I'm not going to treat you, I think this is totally unacceptable. And this is actually hypocritical to some extent, sir. The guidelines say, and those are the guidelines, whether European or American, they say active surveillance should be an initial management option for patients who have significant comorbidities and limited life expectancy. And that's where the guidelines stop. So as you know, the guidelines are not individual decisions. They help us to make decisions, but we as physicians, our job and our duty to our patients to give them a full, comprehensive care and plan. And decision-making is not a knee-jerk reflex. You can't say you are 80, you are not going to have treatment. I think this is not acceptable. There are many factors that we need to consider while we manage kidney tumors. Some of those factors are the tumor biology. Look from the history. If that tumor has been there 2 years ago or not, was it growing like the case we discussed? It was a cystic Bosniak 3 that was observed, and suddenly we ended up with a 10 centimeter aggressive tumor. This is a clear example that active surveillance could be serious sometimes. There are tumor-specific factors like the size. 4 centimeter kidney tumor is not a 1 centimeter kidney tumor. So when we talk about small renal masses, you have to make that distinction. Location. If the tumor is in a central location, studies have shown that it has higher risk of being malignant, not only malignant, but has also more aggressive behavior. Growth rate. I think growth rate is important. If the tumor is growing more than 5 millimeters per year, that could be a sign of aggressive behavior. And the imaging characteristic, is the tumor very well circumscribed or it is infiltrative? Because infiltrative tumors could be also a sign of aggressive behaviors. There are the patient-specific factors. Older age is one of them, of course. It should never be considered as the only factor, though. Shorter life expectancy. If the patient's life expectancy is less than 5 years, I can agree. Maybe active surveillance will be a better option. Of course, comorbidities. Frailty. Frailty is an important index that we as urologists miss all the time. We can make a full lecture about frailty score. I think this is much more important factor than just the age. It's already in geriatric medicine. There's a score from 1 to 9 or 10, I think. And I think using the frailty score is a more precise way of judging the patient. Increased operative risk also to have to consider. Active surveillance is the less risky, but we have, interventions in between. I'm not talking about complex partial, but there's ablation, whether RFA or cryo, that can give us a very comparable cancer-specific outcome. And the sex of the patient is important because a woman who has a SRM has threefold less risk of having malignancy. So male factor is a higher risk of malignancy. The complication of treatment needs to be considered because you can offer thermal ablation. It has increased risk of local recurrence. It has more frequent imaging, potential need for further therapy, but it is very minimally invasive and can give you excellent cancer control rate. Surgery, on the other hand, is whether you do a partial or radical, can have immediate risk, of course, especially partial. We know that partial has high intraoperative and perioperative complication than radical, but it's better over the long term. Active surveillance, of course, is not risk-free. You need repeated imaging, maybe delayed treatment like the lady we just discussed where there's really catastrophic outcome from it because there is no easy option. We waited too much on that lady. She became too old. She became too sick. The tumor grew from 3.5 centimeter to 10 centimeter, and now we don't know what to do for her. So this is one of the drawbacks of active surveillance in elderly. And also, there is also a risk of development and metastasis. What about the kidney function? Also very important. We have to measure, if the patient is 80 but has an excellent kidney function with a 4 centimeter tumor, why would we deny surgery to that patient? His kidney function is not going to affect more. The short-term dialysis, if the patient is going to go for dialysis after an intervention, of course, we might elect for active surveillance. So basically, we have to weigh the risk and the benefit. There is no clear answer for it. When I refuse to treat, if the life expectancy is less than 5 years, if there is high frailty index, if the tumor is less than 3 centimeter, especially in unhealthy patient, or the tumor is slowly growing or cystic. Cystic tumor, as you know, type 3, Bosnack type 3 or type 4, even though there is a high chance of those being cancer, studies have shown that those tumors do not metastasize. There's actually a 0 case of metastasis for Bosnack type 3 tumor. So those tumors are really slowly growing, and if they are small, we can safely observe. When do I treat? I treat when there is a life expectancy more than 5 years, where there is an excellent performance status, when the tumor is around 4 centimeter or between 3 and 4, and the tumor is fast growing or it has infiltrative pattern. So if the patient has any of those, even if he is 80, even longer, we have to keep that in mind. We have always to add on top of that the patient preference. We are not the judge, we are the advocate. We have to give the patient the option, and eventually if the patient decision, if somebody is running and coming with his mother and he's 80 years old, then you cannot tell him. So the patient has to decide whether eventually he or she is willing to accept the risk. So when we talk about treatment, we talk about partial nephrectomy, we talk about radical nephrectomy, we talk about ablation. Biopsy in the elderly is very controversial. It might play a role in the decision making. It's not indicated. Many people will think if the patient is too sick or too old, do a biopsy. Actually, this is the opposite. Because if you do it on the very ill or very sick patient, it will not change your treatment decision-making, even if you see cancer. So it's not indicated in the very frail patient because the results will not change the decision. Whether you do radical or partial nephrectomy, I think both options are viable based on the location and all the other factors I have mentioned. Marchioni et al. In 2019, he studied 4,500 patients from the SEER database. All of those were older than 75. And he showed that actually partial nephrectomy is better. It has lower other case mortality rate than radical. It has lower cancer-specific mortality. And there is no difference in 30 days mortality. And you can see here the radical nephrectomy versus partial nephrectomy, and there is a clear advantage in terms of mortality for partial nephrectomy. Is robotic partial nephrectomy safe and effective in octogenarians? The answer is yes. Udai at the Journal of Robotic Surgery actually recently published an experience of 1,300 patients. He divided the patient in 3 groups. First group was young, which is defined as younger than 65. The second group is old, between 65 and 80, and the third group is very old, more than 80. And he noticed that if you do partial nephrectomy on all of those patients, there's a similar decline in GFR acutely and over 6 months. The operative time and the estimated blood loss is similar. No difference in complications and the trifecta. And the age, when they did a multivariate analysis, age was not a factor in terms of complications or achieving the trifecta. And you can see here in terms of complication and the trifecta, there was no difference between the three groups. What about ablations? Ablation also is doable and safe. Miller, in the Journal of Endourology in 2015, he published his experience of 105 tumors that were ablated, and the mean age of those patients was 85. So this is even more than octogenarian. What do you call it? Nanogenarian. So the technical success was done in 98%. The progression-free survival was excellent, 97 at 5 years. Overall survival, 98 at 1 year, 61 at 5 years, because many of those will die from other reasons. And the complication rate was acceptable. So in conclusion, small renal mass can be life-threatening in at least 50% of cases if untreated. Treatment decision is a complex decision and should take into consideration multiple factors. Age should never be a solo factor in the management, in fact, of any tumor, even for prostate, bladder, and we know about that. So age should not be considered as a solo factor. We can do either radical nephrectomy, we can do partial nephrectomy, ablation are viable, effective, and safe treatment options in the elderly. And we always have to respect the patient decision and the culture of the country where we are practicing, because what the guidelines tell you in one thing and what the actuality, what the daily encounter with patients is another thing. You know, you have patient selection, of course, is the key here. You have to select your patient carefully because not all octogenarians are the same. And we wish you all to age gracefully like the guy on the left side. It's a touching picture, by the way. It's just scary a little bit. So thank you again for the invitation. Thank you for the great, I really congratulate you for the great venue. It's an amazing conference, and I'm happy to answer all your questions.
Thank you, Dr. Rabii.